Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 295 of the podcast. It's January 3rd, 2018. I want to wish you a happy new year. I hope your year is off to a good start, even just a couple days in. I think the podcast here will be off to a good start. There are more episodes coming up this month. But today's guests are Sarah Steinberg of Atrius Health in Massachusetts and Ted Toussaint, a healthcare innovation strategist formerly of Atrius Health. Ted is doing some independent consulting work now. He's also a faculty member for the nonprofit organization Catalysis. So today we're talking about some innovative work that they led and worked on at Atrius together, using a variety of modern product development and innovation methods, including principles and ideas from lean startup, design thinking, and more. And their goal was to create, what they accomplished was to create a new model called Care in Place for home-based patient care that helps reduce trips to a clinic or a hospital. So I saw them present about this work last year at the Lean Healthcare Transformation Summit. Their talk was titled Model Cell, Applying Innovation Process to New Care Model Design. And their work was also featured in an HBR article titled How Atrius Health is Making the Shift from Volume to Value. And you can find links to all of that by going to the blog post for this episode, leanblog.org/295. I hope you enjoy the discussion. I hope you're inspired to look into ways of being more innovative here in 2018. Well, Sarah and Ted, thank you so much for joining us on the podcast today.
Thank you for having us.
Yeah, great to be here, Mark. Thank you.
So Sarah, can you maybe start off and introduce yourself to the listeners, tell everyone a little bit about your professional background?
Yeah, definitely. So I actually started out as a manufacturing engineer in the semiconductor industry, working on the shop floor as an manufacturing engineer. I really loved the high-tech aspect of it, but I sort of found myself drawn to every time a customer would show up on the floor, I sort of was drawn towards specifically designing a product for what they needed. And so I realized I wanted to jump to product development. So over the next 7 years, I've spent working in new product development in the medical device and diagnostic industry. I kept sort of moving more and more upstream, realizing I really enjoyed being in Gemba or being in the place where everything was happening. So in the hospital, working in operating rooms, emergency rooms, ICU, and I just sort of really enjoyed looking for new opportunities and working on then designing and testing new products in sort of the hospital healthcare space. When I was finishing up my MBA at night, I found this opportunity to join the Atrius Health Innovation Center, and I sort of jumped to that opportunity to work with Ted and sort of bring my experience working sort of as an outsider looking into healthcare, designing new products, bringing that experience to sort of work directly with healthcare providers, doctors, nurses, operations people, to sort of improve the way that we deliver care as opposed to adding products to it. So really getting into the service design world. And that's sort of where I am now at Atrius Health.
Well, good. And I'm glad we'll be able to talk a lot today about designing new approaches to care. So thank you for being here with us. And Ted, maybe your turn now. Can you tell the listeners a little bit about yourself?
Sure. So I'm Ted Toussaint, and my experience has been for about the last 5 years or so, been working in healthcare. And I started out as a lean facilitator working at Atrius, and over a period, working on improvement and facilitating event-based improvement and looking at lean management systems. And then a period of time went by and we started to kind of dig more into new product development and design thinking and innovation and how we can apply that to redesigning our work. And that kind of led to the formation of the Atrius Innovation Center, which I helped kind of develop the business plan for, and we, designed what that business model would look like. And so then in that, I became more like a new product development engineer, but really focused on doing care model design. So spent time doing that at Atrius with Sarah, and now I'm working both independently and as a faculty member for Catalysis, which facilitates the Lean Healthcare Network, and I'm doing teaching and consulting around innovation in healthcare delivery.
Well, great. And before we dive more into talking about the Innovation Center and this one initiative in particular, Ted, you mentioned kind of an evolution that a lot of organizations have gone through, from lean improvement events to focusing more on management systems and daily improvement. Before we talk about innovation, can you give a little bit of the background about lean at Atrius Health, and then maybe kind of bridge that into how the Innovation Center and that approach fits in?
Sure. So Atrius, just for some context, Atrius is a large multi-specialty physician practice in Eastern Massachusetts, serving about 600,000 patients. And in 2009, leadership decided to really focus in on lean as a key strategy for the organization, and did a really pretty deep dive into exploring that. And at that time had a fairly large Kaizen promotion office, or Lean Central office. And so that group, starting in 2009, was really focused a lot on value stream and event-based improvement. I wasn't there in 2009, but I have colleagues who were part of that, so I've heard their stories. And so really focusing on that, but then, kind of as that natural evolution that a lot of organizations have gone through, we were doing a lot of improvement work, seeing a lot of benefit, and then started to think, but what are those larger kind of systems that need to be in place in order to make this more sustainable and to really help facilitate the cultural change? So that's when we started to dig into the managing for daily improvement, and we had huddle boards that we had put up around the organization, and we were coaching leaders on how to manage by process. And then in addition to that, kind of how do we align that all up through a Hoshin-Conry system, and how is that strategy being developed and cascaded through Catchball through the organization? So a lot of those types of conversations and that type of work. And that led to a lot of really, really powerful results for Atrius. Atrius Health was one of the original pioneer ACOs, so one of the first organizations that started receiving value-based payment from Medicare. And as a result of a lot of that improvement work, Atrius was rated number 2 in quality across all of the 30 or so initial pioneer ACOs. So some really, really, really great results from that work. And then that sort of, all of that is sort of what led to the development of this what we're talking about, the Innovation Center work, because I was part of that Lean Central office, and the innovation work sort of was an outgrowth of that team to some degree, in that some leaders were asking the question, what is innovation? Is there this thing with new product development that we can explore? And so a number of us were sort of sequestered off and said, all right, let's go put a team together and kind of research this and do a little pilot around innovation and kind of see what we can learn.
So let's transition into talking about the Care in Place initiative. Can you talk about how that got started? Was there sort of a point where there was recognition of a problem, a need, an opportunity?
Yeah. So the Care in Place initiative was the first full project that we'd run once the Innovation Center was formally established, and really started. It's kind of a tricky question to ask where you start innovation, because if you start it more broadly, that leaves opportunity to research and maybe find something that you didn't know existed. So that's kind of where we started. We said, we're gonna really focus in. We know we need to improve and change the way that we deliver care to our high risk elderly population. So let's start there. So we just started with 3 months of just researching what care looks like for our elder patients and trying to find opportunities. Ultimately, through that research, we did a number of things. We did journey mapping and chart reviews and spoke with a number of different people throughout the organizations. And through that process, we discovered this opportunity. And the opportunity was that some of our patients would call into the office and they would have concerning symptoms. And the nurse triage protocol, so the nurse is answering the phone, they would check these symptoms, and basically the triage protocol said that the patient needed to be seen today by a provider, and that was the care that they needed. But sometimes those patients weren't able to physically come into the office, and that at the time was a total limitation of our system. We didn't really have an alternative besides an office visit except to send the patient to the emergency room. And we knew that based on some of the research we'd done about the system and the quality goals, that if we could prevent ER visits and hospitalizations, that would be a really big win for us if we could prevent those unnecessary hospitalizations. So that became kind of the problem or opportunity that we discovered was, is there a way that these patients don't really need hospital care? They could be seen in an office visit setting, but they can't come in. So is there some solution there that we can develop that can prevent them from going to the ER?
And then once that was identified, what were some of the different methodologies? What was the process to continue working on that?
Yeah, so once that was identified, it really became a lot around how do we kind of develop concepts that can solve that problem. And we had a number of different ideas and ultimately settled in on this idea of an urgent care home visit. So we could send somebody to the patient's house to treat them in their home. And then it really became a lot about kind of prototyping. How can we test whether or not this is going to work without really building out a whole system, and kind of speaking to different stakeholders and engaging them and kind of testing this concept with them to see, is this something that could take hold in the organization? And then from that point, kind of that process of designing it out and building it out and testing, and then doing one visit and then doing 5 visits and then doing 10 visits and kind of learning as we went.
And Sarah, is this a point where when did you enter the picture with the project here?
Yeah, while Ted was working on the this initiative, I was working on another project team. But soon as they were sort of ramping up on this his initiative, we also spent a bunch of time sort of reflecting on our process at that point, and we made some iterations. We sort of treated our process as we treat problems in healthcare. We sort of looked at it, researched what was working, what was not, and then we sort of prototyped new iterations and new aspects of our process to sort of develop what we use today.
And in that process, I don't know if you want to elaborate on this, Sarah or Ted. In the presentation I saw you give at the Society for Health Systems conference, you talked about lean product development and design thinking and lean startup methodologies. How did you decide to pull from those different approaches?
Yeah, that's great. Yeah, I mean, so it was really great because one of the things that's awesome about the Innovation Center is we really try to have a really dynamic team with very different backgrounds. And so we had Ted and a colleague from the care improvement side who knew all about sort of lean methodologies and that type of continuous improvement work. We also had a human factors engineer who really understood a lot of the psychology and of patients and customers. And we took we took lean startup methodologies, and also we had a design thinking person. I came from product development, and also I came from design controls, which is like a medical device framework for innovation. And we realized that we were all sort of bringing different aspects of it that were so great that we were like, we don't want to just choose one and at the cost of missing all the other things. So we sort of took all of this different sort of knowledge and put it together into a process that we thought worked best for the projects we were going to be doing.
And so you'd identified this opportunity. What I hear you saying is, you have elderly patients who needed fairly urgent care, couldn't get to the office visit. The old default might have been going to the emergency room, which might have, I'm guessing, included an ambulance visit. Can you talk a little bit about setting up the I don't know if this is jumping ahead too far in the story to talk about the first prototype or the first pilot. How did you get from kind of recognition of the high level solution that you needed to deliver care at home to understanding the details about what that would look like?
Sure. Yeah. So the research kind of led us to that problem, and then I think the first sort of step in prototyping, and I think this is an interesting just question about prototyping a service, because originally when we were talking about prototyping, I was thinking about, how do we take like tape and build something really, build some physical thing that we can test, but with a service, it's all about what is this process that we're going to use? It's what are people going to say and how are people going to do that? And so it really became kind of identifying what our core assumptions were about this service, and then doing little process tests to see if we could see if those assumptions were true. So one of the key assumptions in this urgent home care concept was that patients would actually be okay with this idea, that they would want somebody to, if they called in and they had a medical need, they would want somebody to come to their home and help them there. And so the prototype in that particular case was, all right, let's sit in the phone room with the triage nurses. And we had a meeting with them and explained the concept. And the prototype was really, okay, when a patient calls in and meets these criteria, let's offer them this visit, even though we don't have the visit yet. We're not going to be able to deliver the visit, so there's a little bit of, customer service kind of navigation there that you have to do, but let's offer it to them and see what they say. Because we're not going to go build out all this infrastructure to handle this type of work if we would hate to build out all that infrastructure only to find that when the first patient call came in, the patient said, actually, I don't really want it. So so that's one example of one prototype that we built, or that it's kind of funny. Like I said, we didn't building the prototype. We just kind of did that little process, and that was kind of our prototype. So that's one example. And then I think from there, we kind of got that validation. We did some of that type of work with internal customers, with the physicians and other nurses and administrators to kind of run concepts by them. But then at some point we got to the level where it's like, all right, we need to test this other assumption, which is if we send somebody to the patient's home and we can treat them at their home, that we can prevent an ER visit. So that was that next level of depth. And we really felt the only way we could test that truly was to actually run a visit. And so then the question became, how do we run that visit fast and quick, and again, not build out this whole system around it, but just kind of do it once and see if it works. And so that became a different process of how are we going to find that person, that provider to do it. So we had a nurse practitioner that was part of another home health program at Atrius, who was sort of a colleague and friend of the team. And we kind of phoned in a favor and said, is this can we try this with you? Would you be willing to dedicate a day to help our team to try this new concept? And so we weren't allocating a whole FTE or a person dedicating time. It was just kind of this quick little test. And then from that, we ran a couple of visits and said, and we were able to show, went into the home, the patient had a UTI symptoms, we're able to correctly identify that, prescribe antibiotics in the home, get them the treatment they needed, and that prevented an ER visit. And so when we had that information, that became sort of the green light for the next level of, all right, how are we going to continue to build this out? Is that, that's kind of the flow there.
Yeah. And what were some of the initial criteria? If it sounds like, and one way of stating this might be a plan, do, study, adjust cycle. You were planning, you did that, you provided care to the first patient on a limited basis, maybe a few other patients. How are you studying and evaluating? You mentioned trying to reduce ER visits. What were some of the other goals or measurables?
Yeah, I think some of the other goals were around, we'd done a fair amount of research into patient needs. And so we had identified 7 core patient needs. And one of those needs was patients want to stay in their home. They don't want to leave their home for care, especially in the elderly population. And so that was, preventing the ER visit was a clinical outcome, but it was also a patient need outcome. And then there were these other things, such as patients want to feel like they have support when they have a problem. They want to have lowest life impact. They want to maintain their autonomy and maintain their quality of life. And so we were kind of, after every visit that we had, we got on the phone and called the patient and had a set of kind of follow-up questions that we wanted to ask about how was that experience. And from a more qualitative point of view, though, really at this point, because we didn't have clear metrics that we were trying to hit. It was more exploratory. It was more, we just did this thing for the first time. What happened? What was the patient's perspective? What can we learn from how they experienced that? So that was one. And then I think another thing, that's on the patient side. And then there's also sort of the operational side too. So when you're doing something like this, there are so many different details that need to be thought through, like, okay, so we're going to go see this patient, and how's the medical record going to be updated, and how is the provider in the field going to have access to the internet to get onto the medical record, and are there going to be coverage issues in the 4G iPad, or once that medical record is in, how are we following up with that? What's the workflow, and who should that go to? And does it go to the PCP, or does it go to the provider who provided the visit? And how are we making sure that if the medications are ordered, that those are getting to the house? And so there are all of those kind of more detailed operational things to think through that we had to really reflect on. So we had a lot of reflection after each visit. Is it okay if I add some color to what Ted was saying? Awesome.
Just from a process standpoint, what Ted is really describing is our, what we call our ideate and iterate phase, which is really like our prototyping and testing phase. And the way we look at it is kind of like a funnel. So at the very top, you only want to be putting in, designing, and then testing something that like people actually want. So, in care model design, we often talk about the biggest waste is making something nobody wants. And so we really want to make sure that, even if we're doing a very small portion of it or like a very high level version of what we're trying to create, we want to find out very quickly if this is something that our patients really want. And so like Ted was saying, we call them, we meet them at their house, we ask them how it was, what their experience was, what we could have done better. And only after we are like pretty sure and very confident that this is something that they actually want, then we dig sort of deeper down into the funnel and start doing subsystem and then component design. And so, at that point, it's like they want these visits in urgent care visits in their home. It prevents them from going to the hospital. But how can we do it faster? Do we use an Uber? Do we use our personal cars? Like Ted was saying, what type of Wi-Fi do we need? What type of connectivity do we need? How do we make this faster, better, better experience for our patients, knowing that it's overall the right thing to do? So
yeah. Now, you remind me of some of the lean startup language when you talk about the waste of building something that customers don't want. So it seems like there's elements of lean startup. You talk about meeting needs, discovering unmet needs. One thing I was curious if you could dig into a little bit, Sarah, or elaborate on, maybe this ties back to your background as a manufacturing engineer, the idea of quality function deployment. I don't know if at this point you would call it a traditional method. I remember learning about it, in grad school 20 years ago. Can you talk about this process of translating needs into features and sub-features, kind of elaborating on how you guys did that?
Sure. Yeah, I would be happy to. And Ted, feel free to jump in. So the quality function deployment is something that in product development and here with care model design, we've been able to use a ton of times. It's a tool I love to use, and it's really that it's that getting into the customer needs, understanding, like Ted was saying, some of the people want to stay in their home, people want to have convenience, some of these things, and really getting down to sort of an actionable customer need, and then also prioritizing them, which is so key and important. Sticking to the problem identification phase and just really understanding the unmet needs and the problems. And this is why I love QFDs so much, is that you put them all on a list, a prioritized list, and only then do you jump to solution space and sort of talking through what overall, so top level, what's the system design need to be to meet these needs or to meet the highest priority needs, and only then, once you come up with like an overall system, then you dive into the subsystem design and how are these subsystems enabling the system to work, but also meeting the needs again, and then diving even deeper into component design, and sort of letting that matrix of how much a particular component or feature solution meets the customer needs and how well they do. It helps you prioritize what to develop and what needs to be tested sooner rather than later. So I think it's almost like a great design tool, and then it turns into a great project management tool that really lets you sort of drive what needs to be tested and designed first, and what's the highest priority to meet the most customer needs.
And Ted, do you have anything to add on that, or would you? The next question that came to mind, for either of you is, I'm sure you didn't have unlimited time, unlimited budget. What was some of the process for prioritizing some of those different options for meeting some of these needs, or just prioritizing the ones you thought might have the greatest impact?
Yeah, I think in terms of that, the biggest challenge we had was converging on the idea that we needed to do this urgent home visit. We had, in our research phase, we discovered because remember the research phase started with just very broadly high-risk elder population. So we found a lot of different things in the system that could be worked on with that. And especially in that kind of exploratory research mindset, you enter this very kind of divergent mode. And we came to kind of refer to that as divergence momentum at some point, where it's like every question you answer leads to another question, and it becomes this very energizing state to be in because you're constantly uncovering new things. At some point, the organization says, all right, you guys have to build something. And that's a really kind of painful moment in this process for the project team to bend that divergence curve and say, all right, we're going to stop the research. Yeah, there's a million things out there probably that we haven't learned about yet that could be even bigger than the ideas that we have now. But from a practical resource standpoint, we have to pick one of these things. So for us with the Care in Place project, that really was kind of a moment where we said, looking at all of the things that we had, where do we really think we can have the biggest impact? And the problem that we described earlier about the patients calling in and us sending into the ER really was the one that felt the most impactful, because this was a huge area that we could make impact on important organizational metrics. There was clear financial kind of model that we could build around this, because a lot of those elderly patients, when they went to the ER, were being admitted to the hospital. And because Atrius Health had such a large portion of their patient population on value-based payment, if we could reduce unnecessary hospitalizations, it would be a really huge system impact. So that was kind of that point of convergence, though. Looking back on it, it's easy to kind of make sense of it all. In the moment, it was like a really kind of painful, it was sort of like a grieving process to let go of all these other ideas that we had. Yeah.
And I'm sure the business case, the financials work out very differently here, since Atrius Health is not a hospital care provider. That reducing that hospital expense did flow through to the Atrius Health bottom line, in addition to providing better, more satisfying care for the patients, right?
Yeah, I think that really was a key component to this model, was that because Atrius doesn't own hospitals, when we reduced hospital admissions, that was only seen as basically a reduction in total medical expense from our side that went to the bottom line, and not a reduction in revenue in a hospital that we might have owned, because we didn't own any hospitals.
One other question that comes to mind, you talk about discovering patient needs, design thinking and lean startup approaches, and even the Toyota product development system, all involve stories of observing customers living their lives, or using products, or using competitors' products. Last week at Lean Startup Week, people from Intuit, the software company, talk about a process that they call follow me homes, I think is what it's kind of an awkward noun verb. But with permission, they follow customers home and they observe them using products and discover some unmet needs that led to, for example, they have a QuickBooks version of QuickBooks for people who drive Lyft and Uber, and kind of a solo employee business version of the product. But back to the case here, how much where did you find the balance between asking patients versus sort of trying to observe and maybe trying to discover things that people might not have volunteered during an interview? Did you have a chance to actually go and observe, or did you do that through the early visits of just observing and seeing how that was going?
Do you want to take that, Sarah?
Yeah, sure. So, so to underscore all the things you said, we totally believe in that concept of there's only so much you can ask someone before you have to start, getting in the context of their life and what they're doing and how they're interacting with the services or products we're delivering. And so we spent a ton of time not only talking to patients, but like trying to immerse ourselves in their life and how they interact with Atrius Health and how they interact on the phone and in their homes. And so we spent a bunch of time in their homes observing. We also, I know Ted and the other teammates specifically for this project did a bunch of ride-alongs with the nurses who were going into the home, sort of watching that and interacting with the patient. for some of our other projects, we've gotten the opportunity to spend time with patients in their environments, sort of throughout the care pathway. So, it's one thing to talk to a patient on the phone while they're in the hospital. It's another thing to sit there and to watch them, struggle with navigating the system. I talked to one patient at one of our local hospitals. I went to visit her, and just watching her try to order breakfast was so much learning, and it was incredible to sort of reflect on that and to see it firsthand. There's just nothing comparable to sort of getting those latent needs that you're not going to discover it's not going to be something they can articulate, but if you observe it firsthand, it's something that you can incorporate into your solution.
Yeah. And, that it's like that observation, seeing people struggle with lead, there's a lot of empathy involved in watching somebody struggle, and can you touch on you guys talked about this at the conference. I think it was you, Sarah, who spoke to this, the difference between empathy and sympathy when kind of observing customers or patients.
Yeah, that's a great question. So we sort of take our empathy very seriously, in that it's one thing to sort of listen to someone and feel bad for them and sympathize with them. It's like, wow, that must have been terrible. But empathy is really, taking yourself out of your own biases and your own perspective, and just putting yourself in their shoes, putting yourself in what it must be like for this patient, and just trying to like completely immerse yourself in their perspective and their point of view, and in from their lens. And that's actually something that, it's something that we really try to do. And one of the other things we try to do is what we call sort of an empathy transfer. So it's one thing, for you yourself to observe it, but obviously you have a team as well as an organization behind you that you have to go back and develop a solution and promote the solution as the path forward. And so we spent a lot of time at the Innovation Center figuring out good methods and good ways of taking that time in the field, taking that time in a patient's home, in the hospital, in our clinics, and how do we sort of take that empathy that we felt and we were in their shoes, and how do we bring it to the broader organization?
Yeah, and so what I hear you saying is empathy is putting yourself in someone else's shoes as opposed to just feeling bad for them. Is that a fair summary?
Yeah, and it's exactly. It's one thing to feel for them or understand that they're going through a tough time, or that they're experiencing something. It's another to sort of make it personal and put yourself in their shoes and like be like, how would I feel if that happened? And what are they going through, like from their eyes, from their perspective?
Yeah. So in this important work, I mean, you both have talked about, benefits for patients, benefits for Atrius Health. How would you summarize what were some of the numbers and results from initial use of the Care in Place process?
Yeah, so I think the initial results from that were pretty impressive up front. And what we found was that for these patients that we'd identified that were calling in on the phone, when we sent someone to their house, we were able to keep them in their home, and through a series of questions with the providers and the nurses and the patients asking what they would have done had this not been available, they said that about 50% of the time that patient would have been sent to the ER. So we had sort of like a 50% success rate in that work. And the other time it was basically that the patients wouldn't have been sent to the ER, but we weren't really sure over the phone at that trigger point of the visit. So that was kind of initial results. I think as the program has scaled up, the model was sort of spread to the other 25 Atrius Health clinics, that percentage has decreased to, I think, around 40%, just kind of as the system has stabilized. And the overall numbers, I think, so if we're looking just at 2016, which is when this started, that we started prototyping in 2016, and by the end of the year, we'd scaled it to a number of different clinics. And by the end of the year, we'd seen 300 total care in place visits, and that had resulted in 118 patients avoiding the ER. And then we also kind of then were able to suggest that there's a subsequent number of hospitalizations that were prevented from that. And based on the data we had about how likely certain conditions in patients were to be admitted to the hospital, we estimated that was about 50% of those 118 patients that avoided the ER would have been sent to the hospital. So that's kind of at a scale in 2016, 2017, the work continues. And I think 2017, I'm looking at the numbers here. Yeah, so 2017, there were 518 home visits provided so far as of August, actually. So that's as of August. So pretty large. We were able to kind of scale that quickly, and it has had a pretty significant cost savings. I think the total reduction in total medical expense is about $1.5 million across all those $1.5 million across all those visits.
And I will say, from a patient experience sort of qualitative standpoint, this has become a market differentiator in our, the Boston healthcare market is a very, very competitive one, and it's something that we're realizing patients are seeing this program as, something that differentiates us from our competitors. It's like something we can offer to them. It's been exciting.
Oh. Yeah, so it sounds like there's some great results. The spread of this process from the initial clinics out to the other clinics sounds like a really good news story. So, so we're getting a little short on time as we wrap up here. Mm-hmm. I'm curious, if each of you would maybe share one thing that really surprised you through this process, or one key thing that you learned that you might want to share with the audience as a final thought.
Yeah, I think for me, through the journey of this work, my big takeaway is that this deep customer insight is a complete game changer. And with my previous work in the value stream improvement, I don't think the level of depth of patient research is quite there. Bringing a patient into a room to get feedback on our current processes doesn't really go deep enough if you're trying to radically change things, because the whole point of this work is to depart from the current process. So feedback on what we do today is not going to help us design what we do tomorrow. And so I think that's my big takeaway is, how do you get at that? That there are processes there that get at those kind of future focused kind of customer insight, and those have been, like I said, a real game changer.
And Sarah, how about you?
Yeah, I think the most surprising and exciting thing for me in being in this process and these types of projects is really just the sort of always be learning, always be discovering sort of open-mindedness that we've been able to develop, and the importance of it. I guess it's just, it's so important to try things and go out there with actual patients. But to try something quickly, go back, iterate, reflect on it, come up with a new design, and then go back out and try, and just sort of how that has to challenge you to have an open mind to it, and try to keep your biases out of it, and to really appreciate and identify good solutions when they come across. It's just something that has been really exciting to be a part of.
Well, great. Well, thanks to both of you for sharing. Put you on the spot for some reflections there, but thank you for taking time to talk about the care in place model I would encourage people to go. I'll link to it in the show notes. The HBR article. Is there anything else out there online? I guess people can do a Google search for Atrius Healthcare in place. Is there anything else out there you would point them to, or are those the best places to read more?
Yeah, I think those are the great places to read more about Atrius Health and our innovation center. I would also say Medically Home program is what we're working on now, a home hospitalization program. And if you go to medicallyhome.com, that it sort of gives you an overview of the startup that we're partnering with, Medically Home Group, and it gives you some insight into our current project with the Atrius Health Innovation Center.
Well, great. I'll be curious to look at that and encourage others to do the same. So I want to thank our guests today, Ted Toussaint and Sarah Steinberg. Thank you so much for joining us here today.
Thank you, Mark. It was really fun.
Thank you. Yeah, that's great.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.